On behalf of my co-authors, thank you for the opportunity to present today. In terms of disclosures, Dr. Becker has received advisory honoraria from ViV Healthcare. Other co-authors have no disclosures. HIV incidence among adolescent girls and young women in South Africa remains strikingly high, 3 to 7 per 100 person years. Preventing HIV, particularly in young people, can avoid a lifetime of HIV infection and associated health issues and costs. Long-acting injectable cabotegravir, or CAB-LA, is far more effective compared to tenofovir emtricitabine, or TDF-FTC, for HIV PrEP among cisgender women in sub-Saharan Africa. However, one key barrier to implementing CAB-LA is its anticipated high cost. In this analysis, we asked, how much should we be willing to pay for the improved efficacy of CAB-LA over daily oral TDF-FTC PrEP among adolescent girls and young women in South Africa? Our objective was to identify how much CAB-LA could cost while remaining cost-effective. We examined 2 strategies among adolescent girls and young women ages 15 to 30 in South Africa: daily oral TDF-FTC and injectable CAB-LA. Using the cost-effectiveness of preventing AIDS complications, or CPAC model, we simulated a population of cisgender adolescent girls and young women with characteristics similar to those who would enroll in FastPrep. FastPrep is an ongoing, adaptive, adolescent-focused study employing PrEP products at different venues in a district in Cape Town, South Africa. We used an approach similar to a prior analysis comparing CAB-LA and TDF-FTC in a US setting. We modeled 2 cohorts without HIV at model start, a primary cohort of cisgender adolescent girls and young women and a cisgender male cohort. Results were scaled to a population of 10,000 adolescent girls and young women to approximate a district size. Outcomes included averted HIV transmissions, life years, costs, and incremental cost-effectiveness ratios, or ICERs, dividing the difference in costs by the difference in life years for each strategy compared with the next most costly strategy. We considered clinical benefits and costs over a 10-year horizon with a 3% discount rate. We focus on an outcome called the maximum price premium, which is the price difference between CAB-LA and TDF-FTC. There is no single accepted willingness to pay threshold. For the primary results, we used the threshold of 50% of South Africa's per capita GDP, $3,500 USD per life year, which has been used as an acceptable return on investment in South Africa, and then we vary this threshold widely in sensitivity analyses. We calculated the maximum price premium at which CAB-LA compared to TDF-FTC would have an ICER below $3,500 per life year. If the maximum price premium is lower, we would be willing to pay less for CAB-LA. If the maximum price premium is higher, we would be willing to pay more for CAB-LA. Select model input parameters included a mean age of 26 years, 660 primary HIV transmissions attributable to adolescent girls and young women, no PrEP HIV incidence of 3.2 per 100 person years, and on-PrEP HIV incidence for TDF-FTC of 1.9 per 100 person years, and on CAB-LA far lower, 0.2 per 100 person years. 2-year PrEP program retention was 88% for TDF-FTC and 85% for CAB-LA. For the primary analyses, we modeled annual drug prices in blue for TDF-FTC of $40 and twice that for CAB-LA, $80 USD. We modeled higher annual program costs for CAB-LA compared to TDF-FTC, $21 versus $12, to reflect higher costs associated with administering injections. HIV-related care costs annually varied from $230 to $1,800 USD. ART costs annually ranged from $50 to $890 USD. Turning now to the results. Over the 10-year modeled horizon, Incident infections among adolescent girls and young women were higher for TDF-FTC, 1,980, compared to Cab-LA, 1,080. Averted HIV infections led to 150 more life years for Cab-LA compared to TDF-FTC. Total costs for TDF-FTC were $6.6 million and were higher for Cab-LA, $7.1 million. The ICER of Cab-LA versus TDF-FTC fell just below the $3,500 per life year threshold. At this willingness to pay threshold, the maximum price premium of Cab-LA would be $40 compared to the price of oral TDF-FTC, or an absolute price of $80 annually. This slide shows the results when we include the benefits which accrue also to the cisgender male partners of adolescent girls and young women. Over the 10-year horizon, total transmissions were lower in the Cab-LA strategy, 220, compared to the TDF strategy, 450. Averted transmissions led to 101 more life years within the Cab-LA strategy. Costs saved from partners were $260,800. This led to a lower ICER compared to the other results, $1,020, and therefore a higher maximum price premium of $51, or an absolute price of $91. This figure is a sensitivity analysis on PrEP drug price for TDF-FTC and Cab-LA, as well as willingness to pay thresholds. The vertical axis shows annual drug price of TDF-FTC from $0 to $180, and the horizontal axis shows annual drug price of Cab-LA from $0 to $200. The dashed line shows the base case TDF-FTC drug price at $40. The solid line indicates Cab-LA base case drug price at $80. The dark blue area indicates where Cab-LA would be cost saving, light blue where the ICER would be less than 50% per capita GDP, yellow 51 to 100% GDP, and orange where the ICER exceeds the per capita GDP and would not be cost effective. The intersection of the solid and dotted line shows the base case result for TDF-FTC price of $40 and Cab-LA price of $80. At this point, Cab-LA would be in the light blue zone and would be cost effective. This black square shows the maximum price premium for the combined cohort results. If Cab-LA price was $91, then Cab-LA would fall just below the willingness to pay threshold for a maximum price premium of $51 above TDF-FTC. However, if Cab-LA was priced somewhat lower, $76, then Cab-LA would actually be cost saving with a price difference of $36. Access and equity for adolescent girls and young women at risk for HIV in South Africa, Cab-LA should be made available at prices within this range. I would like to acknowledge our funders. Thank you.